Things are beginning to look up for us. We no longer felt the need to hide. We are beginning to look around with trust. The nights are long, open, and free. We go to the clubs and meet others like we. After nights spent with others, we thought all was fine. Too bad that we thought that HIV was benign. Our time's been cut short, we've run out of time, but all we can do is pray for a solution to find. If not for us, to others be kind. Stop the spread of AIDS, or our deaths will be blind. Vancouver has been prone to epidemics in the past, and is just as prone to them now. The HIV/AIDS epidemic of the late 90s and early 2000s was a rude awakening for the BC healthcare system. Sadly, the death tolls for both of these time periods speak for themselves. Why and how was this virus being spread? Tyndall has indicated intensive cocaine injection as the primary risk factor contributing to the epidemic, as these users were more likely to exhibit risky behaviors leading to seroconversion. Furthermore, Tyndall has indicated the most risky behavior was sharing needles, followed by unprotected sex.
Zip, zip, zip. The door to my tent opens. The bustle of the pedestrians just inches away. Morning coffee, not mine of course, lingers in the air. It's a new day, sun shining, fair. A gunshot goes off, but it's just in my head. My body feels crippled again, all in my head. Zip, zip, zip. The tent door is shut. Columbia and Hastings in mind, I walk. The last of my money, I spend it with ease, to stop all this pain for the drugs I say please. No needle in hand, but in sight. Compared to the ground it looks clean. I drop my heroin, so I thought. The sun escapes my eyes, parallel to the pain. These drugs that I've had may as well have been a real gunshot. As stated, epidemics have not just been a product of the past. As of late, the Vancouver fentanyl crisis has been deemed a public health emergency by the BC government. The death toll related to fentanyl overdose is on track to reach over 1,400 by the end of the year. It was seen by a local safe injection site called Insight that 80% of all tested street drugs contained fentanyl. Again, the use of harmful substances in an unsupervised and undereducated environment has yielded unwarranted deaths. I think back to a time that I thought all was fine. 13 years old, liberated from the elementary, elevated to the secondary, positive growth in every direction. This is high school. The curriculum was new, friendships became. I remember relating popularity back to fame. It seemed that those around me felt the same way, but it proved to be such that others would fray. The schoolwork became moot, social status became the new curriculum, peer pressure began to build. The liquor came out, autopilot took it from there, left, right, above, below, people falling down the stairs. I couldn't take it. I thought we would be fine, so I stepped into an unoccupied room, or so I thought. Her face was purple, like a ripe plum, but the smell rotten. I stopped, shut my eyes, and thought of a time when I thought all was fine. Although we've been speaking about a very specific demographic, namely the downtown east side of Vancouver, substance-related harm can be seen in many other situations. One substantial example being high school students who are entering the realm of alcohol consumption. These individuals are greatly at risk, noting that the CDC has dubbed alcohol as the most commonly abused substance among youth, in which 4,300 deaths occur annually.
Clearly there are drastic implications for those who use IV drugs or consume substances orally. This leads us to the question, what is currently being done to help mitigate the associated harm? This spawned many hypothetical solutions. However, one rose to the top and has been implemented across many different settings and situations. This solution is called harm reduction education. Harm reduction provides a framework for preventing unnecessary death and disease, and is targeted to specific groups who have been identified as at risk. Harm reduction education can be formal, non-formal, and informal in its nature.
Before elaborating, I'd like to outline the harm reduction education principles. The first is to focus on harms. It focuses on the harms associated with drug use rather than the drug use itself. The second is a prioritization of immediate goals. Harm reduction is stepwise in its nature, with a hierarchy of interventions from the most immediate to long-term. The third is pragmaticism. We must enhance skills, knowledge, resources, and support for people who need to live safer lives, healthier lives. And this is done through pragmatic, realistic, low-threshold programs. The fourth is drug user involvement. So the goal is to involve members of the community, therefore creating a wider outreach community. The fifth is respect for human rights. So it does not insist or object to abstinence and acknowledges the active role of the drug user or alcohol drinker in harm reduction programs. And the sixth is to maximize intervention options. So choice and prompt access to a broad range of interventions is what keeps people alive and safe.
In more concise terms, Marlett described harm reduction as such. Rather than defining substance use as a disease and moral failing, harm reduction proponents stake out a humane and practical alternative, meeting clients where they're at in order to educate them about the risks involved in their behaviors, then make appropriate decisions about their own treatment and life goals. We believe that harm reduction education adopts both a humanistic and behavioral philosophy. The humanistic philosophy is presented in harm reduction, as harm reduction intends to maintain the freedom and dignity of individuals by allowing the person at harm to make informed decisions and to act on their own accord. Moreover, harm reduction operates in a person-centered manner, attempting to help individuals achieve self-improvement and increase their self-regard. As such, harm reduction's educational philosophy is congruent with Spencer and Lang's description of a humanistic philosophy.
Harm reduction also adopts a behavioral philosophy as described by Spencer and Lang. Harm reduction intends to reduce behaviors that are risky to individuals. In other terms, harm reduction aims to reduce negative outcomes, such as disease and overdose, and increase positive healthy behaviors, such as using new sterile needles for each injection, or reducing alcohol and drug consumption to less risky levels. As such, a behavioral philosophy is an integral aspect of harm reduction education. Clearly, a common thread among both of these philosophies is the use of education as a tool to prevent harm and improve individuals' livelihood. Now that we've established an understanding of harm reduction's orientation and intent, we would like to look at where and when this education is actually being facilitated and what the content is exactly being taught.
As we have stated, harm reduction can be applied to a wide range of situations, one of which is underage drinking. Within the school system, education regarding alcohol consumption is an incredibly contentious topic. Depending on the state, province, or country, the education on this topic will differ. American schools tend to have a zero-tolerance policy and promote abstinence as a main form of harm prevention. However, due to a study regarding the benefits of educating middle and high school age students about healthy drinking behaviors, rather than purely promoting abstinence, public schools across all states of Australia decided to adopt an alternative harm reduction curriculum. The aforementioned study was conducted by Nyanda McBride, aimed to assess the effects of harm reduction education in high school drinking behaviors. The control received no programming, and the intervention group received the school alcohol harm reduction program called SHARP. This program conducted in a class in a formal manner over 2 consecutive years. Program activities incorporated individual and small group decision making and discussions based on scenarios suggested by students, all with an emphasis on identifying alcohol-related harm and strategies to reduce harm.
The results were incredible. Intervention students were significantly more likely to be non-drinkers or supervised drinkers when compared to the control group. During the first and second program phases, intervention students consumed 31.4 and 31.7% less alcohol, respectively. The use of harm reduction in a formal education setting was proven as effective, which led to SHARP's integration into Australian educational curriculum. Given this evidence-based program, you would assume that this would be widespread by now. However, most of North American schools maintain their zero-tolerance, abstinence-based approach. This begs the question, what factors contribute to reluctance to North American schools adopting this philosophy? Is it due to a cultural difference? Is it due to a top-down political regulation? We leave these questions for you to ponder, and we look forward to addressing these points with you shortly during our discussion phase of this project.
Harm reduction is not only supported internationally, nor is it limited to alcohol reduction in schools. In fact, harm reduction education is utilized by many organizations here in Vancouver. As described earlier, the HIV and AIDS epidemic was a devastating period for the Vancouver healthcare system. In 1989, the municipal government decided to fund a needle exchange program, which was implemented by the Downtown Eastside Youth Activity Society. The goal of a needle exchange program is to have injection drug users always using clean needles, reducing the risk of spreading HIV and hepatitis. Furthermore, to educate users about the increased risk of HIV/AIDS infection when sharing needles. For every clean needle given out on the street, a used needle must be returned, therefore reducing the number of harmful needles left in the community and reducing the frequency and need for sharing dirty needles. Today, there are multiple contributors to the needle exchange program, such as the Vancouver Richmond Health Board, who provide needles and safety information within community health clinics across the Lower Mainland, along with the Vancouver Street Nurse Program, which operates on foot in the downtown east side and exchanges needles on a 1-to-1 ratio, while educating users on vein maintenance, sexual safety, and infectious disease risks.
This education is informal in nature and is phenomenal at breaking down the barriers for educating individuals about such an important topic. Flynn and others describe 3 different sets of boundaries to adult learning, of which we believe that harm reduction education by the needle exchange program overcomes 2. An institutional boundary noted by Flynn and others was when curriculum is not applicable to in-class teaching by registered educators. This is overcome by taking the education outside of the context of a classroom and employing individuals who have first-hand experience regarding the curriculum to be the ones actually teaching it. Secondly, we believe that a dispositional and motivational barrier is overcome. We believe that the negative perception of drug users in the downtown east side is a significant deterrent for a user to seek education provided by that wider community. By using teams that have developed rapport within the public and user community, such as the street nurses or social workers in the area, education is easily brought to the user without having to motivate the user to seek the education themselves.
The needle exchange program became accountable to the provincial government in 1992 and subsequently went on hiatus for the following year due to removal of funding. We believe that this represents early neoliberal politics. Archives and provincial hearings indicate that the removal of funding was due to funding allocation being centralized to specific regions of the province rather than distributed evenly. With the efficacy of the needle exchange program blatantly recorded and stated, it was baffling to many healthcare providers that the program was no longer funded. At the time, no comprehensive analysis regarding the needle exchange program's association with the healthcare costs was conducted. Yet, we can only assume that healthcare costs regarding HIV and AIDS treatment were significantly decreased, given that the proven reduction of HIV and AIDS transmission facilitated by the needle exchange program. For these reasons, we believe that this neoliberal orientation was taken by the provincial government at the time.
Another form of opposition that the needle exchange program was, and still is, held by many individuals in the community. This opposition is due to the erroneous belief that the exchange of needles fosters an increase in drug use. When the needle exchange program was under municipal control before 1992, research was conducted and the City Council concluded that the needle exchange program did not increase drug use in Vancouver. It is our opinion that this is the exact scenario that relates back to the negative connotation behind radical education. We believe that harm reduction education as a whole exhibits a radical and critical philosophy. By often going against social norms, as described earlier in alcohol education, by taking a stance that's not normal for American schools, and as described now with the perception of the needle exchange program. It's integral that society begins to recognize that radical education does not inherently mean radical change. It means changing one predetermined normal into a more beneficial, up-to-date normal for modern society. We would like to hear your opinions about the opposition to the needle exchange program and towards radical exchange education as a whole. We interviewed a nurse named Heather Anderson who works for Vancouver's first safe injection site, and that's called Insight. Insight opened in 2003 and was the first legal safe injection site in North America and is operated, employed, and funded by Vancouver Coastal Health. Insight is localized in the downtown east side and operates under a harm reduction model. Similar to the needle exchange program, Heather states Insight's goals are to reduce the transmission of infectious disease, along with refer clients to alternative medical care facilities and services, such as counseling, social housing, or detox. Heather believes that these clients that she aids have been marginalized with regards to the healthcare services provided. Heather believes that there's an overwhelming stance held by society that those who are alcohol and drug addicts are simply just beyond help. Heather argues that Insight has broken down the barriers between the healthcare system and the users of the downtown east side, and asserts that Insight facilitates honest, trusting relationships between healthcare professionals and users, which yields actually incredible results. Scientific literature has indicated that Insight's success in the following areas. Increased referral to health and social programs, reducing the number of overdoses experienced, reducing the transmission of bloodborne infections such as HIV and AIDS and hepatitis C, reducing injection-related infections, and increasing public order. We congratulated Heather on these accomplishments, to which she agreed with their validity, but yet added that there are many more.
Heather's anecdote entails that she has seen clients transition from high-risk drug users to clean individuals, and believes that the opportunity for such a transition would not be available without a resource such as Insight. We asked her about her educational style. Heather indicated that patience, positive regard, and empathy were integral. We asked Heather about her experience as a female with a male-dominated client demographic. Through a review of a study conducted by StrathD, it indicated that 65% of intravenous drug users were men. Heather spoke of the need to educate genders in different ways, ensuring specific attention gets paid to women's special needs. She spoke of the prevalence of sex work within the population she encounters, and the need to reduce the harmful effects from the stigmatization of sex workers. Increasing the social inclusion of those working in the sex trade seems to be useful in mitigating harm facing the workers by encouraging the use of safe sex practices and promoting techniques to end sexual exploitation. Tackling systemic issues that put women at a disadvantage is congruent with the feminist perspective on education discussed in the course by Butterwick. In conclusion, when considering aspects of mental illness and substance abuse, we think it's important to consider the way society views disability altogether and highlight aspects of harm reduction in contrast to the medical and social models of disability.
Many of the social and structural barriers facing people with mental health and addiction issues are related to the medical model of disability. The medical model focuses on disability as an impairment and a personal tragedy, and the need of the individual to adapt to fit within society as much as possible.
On the other hand, the social model of disability says that the disability itself is caused by the way society is organized, rather than by a person's impairment or difference. Focus on the social aspects of management allows us to look at ways of removing barriers that restrict life choices for those with a disability, such as mental illness and substance abuse.
With this being said, we believe that the social model of disability should be adopted when addressing the current epidemic facing Vancouver, which we have previously indicated is the fentanyl crisis. Moving forward, it's our opinion that barriers to safety need to be broken down regarding recreational drug use, and we believe that the harm reduction approach is an avenue to actually accomplish this. It's not the drug user's fault that fentanyl has ended up here.
Therefore, it is necessary as a society to adapt. By implementing drug testing in community locations such as clinics, hospitals, or by creating mobile services that can test drugs, we believe that there will be a resulting decrease in the number of overdoses. Moreover, education can be facilitated on how to test drugs at home and what safer methods of drug acquisition can be employed by the user in order to reduce the number of doses and save lives. This is harm reduction education.